Basically, so let's run through this evening some of the congenital hand deformities. And I think to start off with, currently in the environment we're in at the moment, it's not called congenital hand deformities anymore, it's congenital hand differences. Okay, so instead of a deformity, it's a congenital hand difference. And that does make a difference when dealing with the parents. That is not actually a deformity as such. So we're going to just get our next slide up. Okay, so basically, if you look at the classification of congenital hand differences, this is the old classification. I still like it, it's good. It's Swanson's classification, and it's 7 is failure of formation, failure of differentiation or separation, like a syndactyly, a duplication, like a polydactyly or a thumb duplication, overgrowth, congenital constriction band syndrome, miscellaneous, and generalized skeletal abnormalities. I assume I'm mainly talking to orthopedic surgeons. I'm not sure who else is on the side, but basically, guys, for you, this talk tonight really maybe is just of some interest, and you might pick up some stuff going forwards in your careers that you might want to use. It is of no use whatsoever to your exams. So if you guys want to go have a beer or a glass of wine or take your wives, girlfriends, partners out, go for it, okay? Because it's really, you will not be asked any of this in any orthopedic exam. It just doesn't form part of the exam itself. But it's still interesting because a lot of it sort of encompasses both orthopedic and plastic surgery principles, but a large part of it falls under the plastic surgery curriculum. Okay, so this is the old classification. More recently, a year or two ago, a couple of years ago, they've updated the classification system. So it's now called the OMT classification. It's Oberg, Mansky, and Tonkin. They're 3 big-time congenital hand surgeons around the world, along with an international group. And it gets quite complicated because essentially it's based on deformities, dysplasias, and malformations, okay? And what they've done is really classified the hand as preaxial, axial, or post-axial. So it gets very complicated. We've actually got a big thing up. If you look, if you do the fracture clinic at Red Cross, you'll see on the wall behind you, there's quite an extensive classification of the new classifications, the OMT classification. But I think for simplicity's sake, we still stick to the old classification because it makes sense. Okay, a few examples. So failure formation is fairly obvious, isn't it? So these, for example, the slide on the left and the top right is a failure formation. It's what we call a transverse arrest. An elbow joint is present, maybe some rudimentary sort of little finger buds on this left-hand slide, my left-hand slide, but nothing else. Now these children, and this theme goes throughout congenital hand surgery, is that they're all incredibly functional. So we operate, some of our general principles are we operate for function, not for form. What we mean by that is we operate to improve function. We don't necessarily operate to improve the look or the appearance of the limb. And you've got to sort of remind yourself of that all the time, because it's very easy to get sucked into saying, okay, look, we're going to operate and make it look better, etc., etc. But they are incredibly adaptable, these kids. They get on with things. They are able to do the most remarkable things. These kiddies with these transverse arrests, we don't send them for prostheses. They don't use them. They outgrow them. It's of no use whatsoever. They use on this side a basic grip. We call this grip a brachythoracic grip. Brachy being limb, thoracic being the thoracic cage. And they hold things between the arm and the thoracic, brachothoracic grip. And some of them incredibly functional. Another example of failure formation, a shortened limb, this we could really classify as probably brachydactyly, sim together, brachydactyly, small, short hand. And here it goes back to the principles of, again, you wanting to achieve function. So in a limb like this and a hand like this, you're saying really this is sort of a spoon-shaped hand. You want to give them some sort of thumb or some sort of finger that they can oppose to. So you want to achieve some sort of pinch grip. So you want to use one of those fingers or thumb in inverted commas and convert it into a thumb. So that's what we're doing on the right hand side here, is we are doing a type of a pollicization. It's not really an absolutely correct one, to achieve some sort of basic pincer grip to give them some function. Okay. Some more examples. These are classified as really as probably a cleft hand. Okay. Where your failure formation is central, isn't it? I mean, you've got a radial side where the thumb is. You've got a, let's get rid of that, an ulnar side, but you don't have your central raise. So there's 1, 2, 3, 4 fingers, and there's no central raise. So in this case, there's a central failure formation. The middle ray has failed to form. A bit later on in the presentation, I'll run through exactly what we do with these sort of hands. And like the example on the left, yeah, so that we call it cleft hand. It used to be called a lobster claw hand, which is a terrible name for it. And these we will say they are a functional triumph, but a social disaster. The child can do just about everything with that type of hand, but really it looks very different to what normal looks like. Okay, another failure from a central failure. Okay, this actually nowadays would be classified as sort of an ulnar failure. They've got a basic, there's an ulnar dimelia here, but we won't run into those technicalities. Just think of it as the central rays haven't formed. So this is the sort of thing that we do with the general principles of that cleft hand we looked at just now, is to say, okay, we've got the central failure formation, there's no finger there. What we want to do is we want to transfer the index finger. We want to transfer the index finger towards the middle finger, and at the same time we want to improve the web space between the thumb and the index finger. So this procedure is actually called a Snow and Littler procedure, whereby what you're doing is you're using that central big flap of skin to transfer it into the web space, and you're shifting the index finger across. So this is the sort of the bottom right screen. I don't know if you can see my arrow, but the bottom right, my right, you can see now we've shifted the index finger across, K-wide in position. That little flap of skin you see between the index and the thumb used to belong between the index and the middle. So we've transferred it right across to improve the web space. And that's a good procedure, because you improve your web space, you get better pinch, the hand looks more normal, and function remains very good. Okay, let's move on to the next one. So again, you see the same example, top left, a different child in the bottom right, also with a cleft hand. Okay, so let's move on to some of the things that we fairly commonly do, and that is to say, okay, guys, a lot of these children have a failure formation whereby there is no formation of the radial side of the hand. In other words, sometimes the radius, we'll move on to that just now, but you get a radial club hand, the radius hasn't formed, and similarly the thumb hasn't formed, like these two different examples. So then what one has to do is say, okay, well, let's transfer the index finger, pollicize the index finger, make the index finger into a thumb. So that's what you achieve. So basically a lot of the work we're doing now at Red Cross is based on stuff which was done at the Texas Scottish Rite Hospital in Texas. And currently their head, there's a lady called Mary Beth Zaki. So that's the technique we use. And really this is probably the most complex operation we do. It's a sort of 15-step procedure whereby we're actually disarticulating the whole index finger. We remember, of course, the thumb has 2 phalanges. The fingers have 3, so we have to remove a bone. So we actually remove the metacarpal of the index finger. Okay, so the proximal phalanx of the index finger becomes the metacarpal, the middle phalanx becomes the proximal phalanx, and the distal phalanx remains the distal phalanx. And then you reconnect the tendons, etc., etc. And they're incredibly functional. So you achieve an awful lot with that pollicization procedure. So that's an example there. This child was born without a thumb. He now has an index finger, which is a thumb, and he's able to oppose and pinch right the way across to the ulnar side of the hand. Now, I wonder whether this is I'm going to play this video, but anyway, this is these pictures are of a gentleman. He's obviously not a congenital patient, but he had his thumb amputated with a circular saw, closed, skin grafted. Here, your options really in an adult are: do you do a toe to thumb? Do you leave him as he is, or do you do a pollicization? Toe to thumb's a good operation, but remember with a pollicization, you're maintaining the neurovascular bundle, so the sensation is always very good. And that's one of the big issues with doing a toe to thumb, is that you obviously have to reconnect the digital nerves, and the sensation becomes an issue. But if you use the index finger, you're using it on its neurovascular bundle, so the sensation is very good. So we chose to do pollicization on this guy. Now, hang on, let's go back previous. Just going to go back a slide. Just want to see if I can get this video to work, guys. Let's go back again. Okay, that's not going to be working, which is unfortunate, but I wanted to show you that video. Okay, let's look at these sort of children that we are going to look at. So basically, again, shortened fingers, symbrachydactyly. In symbrachydactyly, get the monodactylic type, where you just got a thumb present. You can get allodactylic, more than one finger present. In fact, the case at the bottom right is a congenital constriction band syndrome. You can see there's little sinuses, little dimples in the fingers themselves. It's a very clear feature of congenital constriction band syndrome. So basically, in these children, like for example, the top left, you've got a reasonable thumb, but you want to give some length to the fingers. You want to give some length. So the thumb's okay, but you need now a post for the thumb to oppose to. So this is something we do for symbrachydactyly and constriction band syndrome, where we want to increase the length of, say, an index finger or a middle finger. And we do something called a free toe phalangeal graft. So if you look at these pictures, what we've done here now is we've taken off a toe phalanx, usually third or fourth toe phalanx, all right, in its entirety. Okay, so it's a free graft. It's not on a neurovascular bundle, it's on a free graft. We remove it from the toe, we insert it into the finger, okay, and then do your soft tissue coverage. So, I mean, you know, if you think about it, if you take an adult's toe and you take it out of their toe and put it on the hand, the bone will just die. It's got no blood supply. But incredibly, these children's bone lives and grows by diffusion alone until it's got some collateral supply and new blood supply. So not only does the bone live, but the growth plate also lives. So it grows the equivalent of what the toe is going to grow. Okay. And that, you've got to do this operation before a year of age, or at about a year of age. So at a year of age, the survival of that phalanx is about 90% plus. Survival of the phalanx and the growth plate. As soon as you're over 2 years, the survival of the phalanx and the growth plate rapidly drops off to about 50%. So you've got to get in early with these these kids, put it on. So that's an example on this child. If you see on the right-hand side, what does he look? He looks about 3 years old now, maybe, or 4 years old. He's holding a pen. This child had no thumb, no index finger, nothing. So a complete failure of arrest or transformation. So what we've done is we put in, those are toe phalanxes, okay, and they're growing. Put them in at a year of age. You can see the phalanx growth plate, okay, and he's now able, 3-4 years down the line, able to hold a pen and write and draw. So that's an incredible way of giving these children a little bit so that they're able to do. He would have had no fingers whatsoever, and we've given him a reasonable thumb and index finger. So that's called a free toe phalangeal graft. Okay. Another common thing we see, radial club hand. Okay, so failure formation on the radial side. You can see this child, how the wrist is sitting at sort of 80 degrees to the hand, the hand is sitting at 80 degrees to the wrist. And that's because there's no support on that radial side. There's no radial bone. You don't need to know the classification, but for interest's sake, it was Bain and Klug, B-A-Y-N-E, and Klug, K-L-U-G, classified it. It's very simple, really. Depends on how much of the radius is present. So if you've just got most of the radius and not much of a club hand, it's a type 1. If you have no radius whatsoever and a significant club hand, it's a type 4. And then there's a little bit in between. So it's fairly obvious what we need to do with this child. We need to correct the club hands, or we need to straighten this hand out. Okay, this wrist out. All right. And then subsequently, look, he's only got 4 fingers. We need to make him a nice thumb. So we use a technique here called an Evans bilobe flap, which is essentially a flap whereby we do a transverse cut of the wrist crease, and then you've got these long elongated bilobe flaps. So as you're straightening out the wrist, each flap will fit into the next one. It's difficult to explain without showing you, but that's what we do for the soft tissue. And then correct it. But remember, these children, that ulna, the ulna is not normal. The ulna is, A, it's bowed. It's bowed in the radial direction, okay? And B, it's 20 to 30% shorter than the other side. Okay, so the ulna is not normal too. So remember, these children, you don't want to overcorrect them. You don't want to overcorrect them, because what happens then is they're always going to be working with their hand to their mouth. And because that arm is short, you want that wrist to be in a slightly radial direction. The last thing you want is if you throw it off on the other side and you turn it ulnar, then they can't get to the hand to the mouth. Okay. So basically, essentially what you do when you do your club hand correction is you do your skin flap, and then you really do a complete disarticulation through the radiocarpal joint, and you centralize the carpus onto the ulna. Okay, so it's a centralization procedure. All right, you can see on the bottom slide it's nice and straight, and then close your flaps up so you have a straight flap. So if you look at it, how can I explain this? Bottom left side, that flap you're seeing on the radial side now came from the dorsum, and the flap from the dorsum came from the ulnar side. And you close the ulnar side up primarily because there's always redundant skin. So you're just hopping each flap along until it closes. That gives you a nice straight hand. KY stays in for 6 weeks, back slab or some form of protection. Now, if you read anything about a radial club hand, they tend to relapse. So we like to send them to the occupational therapists. At Red Cross, occupational therapists are just fantastic. Without them, we'd be lost. You know, we do these things in theatre, but they need splinting till skeletal maturity, so constant monitoring. So we have a massive input from Muriel Passard at Red Cross. So they're really essential to our team down there. It really is a team approach. She joins us for the clinic, Clinics Mark van der Veld is a plastic surgeon. Myself, I'm an orthopedic surgeon by training. Muriel Passard, who's a occupational therapist and a physiotherapist. So we do a combined assessment and clinic every second Thursday. If you guys are around, you're more than welcome to join. Okay, that's ready. So we centralize this hand, and then add a secondary procedure later on. When everything's settled down, we'll do a pollicization to give him more function in terms of the thumb. There, just some examples of the radial club hand. You can see the kind of top left, little residual nubbin of a thumb. Look what the X-ray looks like, and you can see these. Look at the X-rays of the ulna. See how bowed that ulna is. The X-ray at the bottom, you can see there's a little bit of residual radius left. That's like a Bain and Klug, maybe a 2. But there's some radius present, whereas the others have no radius present whatsoever. Little kiddie bilateral. One thing about the radial club hand, a lot of these conditions, I'm not talking about radial club hand, the conditions I talked about before they're isolated. They are a defect somewhere between the 6 to 8 week of pregnancy, and you get a failure of what we call the apical ectodermal ridge, so the hand doesn't form, or forms in an abnormal way. Radial club hand, a lot of them are associated with syndromes, okay, and with other abnormalities. So you remember the Vater syndrome, V-A-T-E-R, vertebral, anorectal, or radial club hand, tracheoesophageal. So when you see a radial club hand, we send them straight to the genetics assessment clinic, etc. They get an ultrasound, they have a look at the tracheoesophageal, get an ultrasound, they get an echo, and a thorough examination by the pediatricians, because very often there's an association like a Vater syndrome. Okay, these also radial club hands often associated with other syndromes. I'm not going to go into Goldenhar syndrome, Fanconi's anemia, we get platelets abnormalities, etc., etc. So you don't need to know, but just to know to refer. You see a radial club hand, straight to the pediatrician. Say, just please check out this child hasn't got Vater, Fanconi's, Goldenhar's, etc., etc. Okay. All right, failure of separation. Sort of a classic example, and that's a common thing we see is syndactyly. Okay, syndactyly, failure of separation of the fingers. The one on the top left, middle and ring, it's the most common. Complete or incomplete, simple or complex. Fairly simple classification. Top left is complete simple, there's no bony attachment. Complex is when you've got a bony attachment. Slide on the right is incomplete simple. Okay, so we obviously need to separate these fingers, okay, to achieve independent motion of the fingers. There is always an absolute deficiency of skin, always. Even so, you look at this case on the right, you think, oh, we'll just do a little cut down here. I'm sure it's going to be fine. Don't worry about it. It'll be cool. Yeah, wait, you get in there, you find you end up really closing that skin with a lot of tightness. They get a flexion contracture of the finger. They need revision surgery. So they all, just about, when I say all, a few not, but 98% of these children have a skin graft of some sort or another, either a fairly big skin graft like the one on the bottom, or a smaller skin graft like the one on the right. But that skin graft just gives you that ability to close things without tension. Tension's the enemy when you're dealing with syndactyly, because that, if you close with tension, they'll have a revision. Now, the key with syndactyly is not so it's easy to separate and it's easy to skin graft. Remember, we use full thickness skin grafts, less contractile ability. And the full thickness skin graft is from the groin. Okay, the groin's closed primarily. The key with the syndactyly is the web space. Eh? That is the key with syndactyly, to recreate a good web. So the web space is called commissure. Okay, and I I would draw it out for you, but I don't have that ability. But basically, if you think about your web space in your hands, okay, it's so brilliant because you never have to clean. When have you ever cleaned between your fingers? You don't have to clean between your fingers. It's never dirty, is it? You don't have to sit there and clean between your fingers. Oh God, it's so dirty. And it's a self-cleaning apparatus. The design, that 45 or so degree slope, design that the skin is sloughing off all the time in a volar direction, self-cleaning, never gets wet, never gets dirty. So you don't even really think about it, but to recreate that is not easy. So some of the issues we have is you've got to position obviously the web space in the correct position. It can't be too distal, it can't be too proximal. Design your flap properly, no tension on that skin, skin graft, and that's really the key to the problems with this syndactyly is web creep, so they tend to reform, and a bad web space. So we're quite often doing revisions of these from elsewhere. Difficult, this sort of hand, can you see this? It's a complex, complete syndactyly. Some of you might recognize that's called Apert syndrome. Apert syndrome, they've got very typical facial features, facial abnormalities, and then this sort of mitten or cloven hoofed type of hand, and there you have to clearly create some form of web space like we have, and then full thickness skin grafts between them. Remember, in a child, full thickness skin graft will take on bone, it'll take on tendon, it'll probably take on the theatre floor. If you put it on there, it just grows. You don't have to worry if you've got a joint that's open, it'll just take. So fortunately, we don't have any issues with that. And, you can see again, this is a Apert's child, complete syndactyly, and this child's at all 3 fingers released. That's looking good. He's got nice web spaces, minimal web creep, so nice result on that side there. Separating, just some more examples. Duplication, polydactyly. Okay, let's talk about this. So these, you can see they're all thumbs, aren't they? Huh? Duplicated thumb, quite a common difference which we see. The duplication, as you can see from these pictures, can be at different levels. Okay, so if it's at your distal phalanx, then it's A1. Now, the whole classification was quite interesting because classified by a doctor called Wassel, W-A-S-S-E-L. Now, the story goes like this. Wassel worked for a very famous professor of congenital hand surgery called Professor Flatt in the States. And Wassel arrived as a fellow, and by all accounts, Wassel wasn't that great. So Flatt said to him, listen, Wassel, you're not coming to theatre. This is in the old days, talking about the 70s. You're off to go to do some research. I want you to look at these duplicated thumbs, and I want you to work out a classification for me. So then Wassel said, okay, cool, let's look at that. We'll classify it like this. If it's at the distal phalanx, it's a Wassel 1. At the interphalangeal joint, it's a 2. At the proximal phalanx, it's a 3. If it's at the metacarpophalangeal joint, like the one on the bottom right, it's a 4, and that's the most common one, 60% of those, etc., as it goes down. So fairly simple. And then Wassel, to get one back on Flatt, said, okay, well, he's just going to publish it under his own name. So he published it, and it was accepted. And to this day, it's like one of the most common. You speak to any hand surgeon around the world and say, okay, you know that thumb class, Wassel's classification. So Flatt apparently was they're helling about that, but there's no Professor Flatt classification. There's a Wassel classification. Wassel never made it, left medicine, and he sells real estate in California now. So that's where he's ended up, but he's pretty famous in terms of his classification. So to get back to what do we do, obviously from these thumbs, these duplicated thumbs, we have to create one thumb. And when they're duplicated like this, they're both smaller than what a normal thumb should be. So they sort of steal a growth from each other. And based on each different level, there's a different operation which is described to do it. So for example, the one on the top left, really here, you can't just remove one of these thumbs because you're left with, like, what are you going to do about this nail bed, edge, etc. So you almost do like what we call, it's called a Bilhout-Cloquet procedure, and it's French. I'm sure I'm saying it very wrong, but you're taking a central wedge out of that thumb and then bringing the two lateral edges together. Most common is the bottom right at the type 4. Look at the X-ray. Can you see the X-ray? So basically, it's duplicated at the MCP joint. Okay. But now the key with this one, and these, as I said, 60% of cases, it seems simple. I will just chop off this, the extra thumb. It'll be fine. But remember, there's a collateral ligament that you have to take into account here. Okay. So if you just take that off, there's no collateral ligament left, and the residual thumb becomes very unstable. Also, too, the muscles, abductor pollicis brevis, etc., insert into this redundant thumb, which you're going to take off. So you must take off APB, take off the collateral, and reattach it. So we've done here. You're getting a pretty good result. Sometimes if you've got a considerable deviation of the residual digit, you have to do a closing wedge osteotomy. Polydactyly. Worldwide, about 1 in 2,000, very common difference. 1 in 2,000. South Africa, 1 in 200. Very prevalent up in the Eastern Cape. And we started some years ago, about 9 years ago, because we were sending a lot of these to theatre. So we sort of said, but, hang on, got a general anesthetic for a fairly simple problem. Because before that, all that we were doing was they were tying, if it was small enough, they would be tied off with silk or whatever the case might be. Often left the most junior person, so it would be semi-half tied and become necrotic and all of those problems. Or just too big and went to theatre. So we said, no, hang on, let's make it. You can see this is one that's been on the right-hand side tied off, and hasn't been tied off correctly, and it's become necrotic. So that we need to deal with, obviously. The slide on the left, so it's the right side on the left, it's been tied off, but it's hard to get a tie right up into the base of a finger, isn't it? I mean, you've got to be pushing that tie up, and the poor old husband's pushing the tie up, making a hash of it. So he just ties it in the middle, and then you're left with this residual stump, which the parents are not happy about. So we said, come, let's make a plan. So we came up with this idea. This is a UCT idea. We've now done, I think we've published 900 of these. The Liger clip from theatre, vascular Liger clip. Obviously, with a Liger clip, you can get this is done in the clinic. You can get really close up against the base of that extra little polydactyly, clip it off, and cut off the little finger. We do it we put some EMLA on. Maybe it makes a bit of a difference. I think it makes us and the parents feel a bit better. But most, it's once you've crushed that digital nerve, they very rapidly feel they're not crying anymore, and they're happy, and it's in and out. So we do about 10 or 12 every second Thursday in the dressing room. And it's left with you can see these two here. I can't even see the scar on the right-hand side. A little residual scar on the left. So leaves a nice scar, and considerable, obviously massive cost saving to the hospital, and in terms of taking them to theatre, etc. So if you guys are somewhere one day and how are we going to do this? Liger clip theatre, just pop it on and done deal. Overgrowth, gigantism. These can be idiopathic, just occur, or they can be neurally driven. So you get things like neurofibromatosis can cause it. Hamartoma, a hamartoma of the median nerve. Can you see how this hand on the left-hand side, my left, it's mainly the median nerve side of the hand. And that's because the median nerve is massively enlarged and is fueling the growth on that side. So it can be neurally driven or vascularly driven. Okay, so things like AV malformation, hemangiomas, etc., because you've got that overstimulation, vascular supply or neural supply, you get this gigantism. So the one on the left is called a lipofibromatous hamartoma of the median nerve. You don't need to know that, but that's what it is. Massively difficult problem to treat. You know, we try and do nerve stripping, so you cut the median nerve down, strip the digital nerves in these fingers are the size of a normal person's median nerve. They're massive, so you try and strip the nerves down to decrease the amount of neural stimulation. It doesn't really work. Many of them, I'd say 90% of them, end up with some form of amputation, some one or another form of amputation. In the middle, overgrowth of the central 2 digits plus a syndactyly. We've separated it, but subsequent to this child in later years has had an amputation, I think round about proximal phalanx level. We also obviously try and, you know, you want to, if you see them early enough, you want to try and limit the growth. So we do things like check what the parents, size of the parent's hand, the child's hand. When the child's hands or fingers are at the size of the parent's fingers, we do an epiphysiodesis. We remove the physis from all the growth plates in the finger to prevent it growing any further, in the hope that those fingers won't grow, the others will catch up, and they'll all be of equal length at the end of the day. Reasonably successful in some cases. Obviously not in this case, but in some cases you can judge it quite nicely and get a finger that's not too bad with an epiphysiodesis. Congenital constriction band syndrome. Now, the simple way of thinking about this is that there's it's amniotic bands that wrap around the digit. You know, that's a symbol. So it's a mechanical sort of amputation of the digit. In fact, it's a lot more than that. There's a whole lot of biochemical elements and genetics involved and whatnot. So it's not just simply, oh, amniotic band wraps around and off comes the finger. So sometimes they're fairly functional, but they can have amputations right the way up, you know, whole limb, arm, leg, whatever the case might be. Again, if we need length of fingers here, those free toe phalangeal grafts I talked about earlier work quite well. Can you see on the x-ray how you sort of get that appearance of the tip of the digit where it almost looks like it's been constricted, doesn't it? That's very typical of congenital constriction band. But this is just an interesting, this is the mother on the left-hand side and the child. Windblown hand, where the fingers and thumb all drift off onto the ulnar side. The French call it coup de vent, which means windmill hand. There's various things we do with it. I'm not going to go into it. It's not common. Okay, this you guys. Oh God, let me just go back one slide. Camptodactyly bent finger. This I should know something about because someone's going to ask you advice. It's common. And they present obviously with a bent finger, a flexion deformity of the finger, usually at the proximal phalanx. It's a combination of problems. First of all, on the volar side, tight volar structures. The skin is always tight. The flexor tendons are tight, particularly FDS. The volar plate is tight. Accompanying this, on the extensor side, they have very weak extensors. So they're unable to compensate. When you see them, there's sort of two different types. You usually them about a year, 2 years of age. So the type that's fairly soft. What do you mean by that? It's sort of passively correctable. They do very well with splinting. And then you get this sort of tight type, which you're looking at here. Which we try splinting, but not that successful. The take-home message is if these children are functional, despite a flexion deformity, don't do an operation. The operations are unsuccessful. It's multifactorial: flexors, extensors, volar plates, FDS. You can't correct it all. And the last thing you need is to end up with a finger that is now straight and can't bend. That is a proper disaster. Because they all compensate, as you can imagine. They hyperextend at the MCP joint. They clear the palm, and then they're able to wrap around an object. So be very careful of this group, okay? The second thing is you get Camptodactyly. These are youngsters. Not so much one on the left, but one on the right. These are youngsters. And then you get a second group. where the hand is normal, but they develop a camptodactyly when they're about 10, 11 years of age, particularly young girls. Suddenly they're 11, 12, and the mother brings them to you with a camptodactyly. Do not operate on that kid. Do not. So it's a secondary development of camptodactyly. I promise you there'll be tears from the mother, from the child, from you, because they do very badly with surgery. So just reassure them, say, you're not operating, they're functional, clear their palm, and, you talk them through it, get an occupational therapist involved, get some splinting, do all that, but don't put a knife to them, it'll be a disaster. Campto. Congenital clasp thumb, weak extensors. We do tendon transfer, EIP to EPL. We sometimes do a chondrolese of the MCP joint to get them out. Congenital clasp thumb. Okay, going back to. So I know we had quite a bit longer, but I'm going to wrap it up. I've had a big day, big operating day. Tomorrow we're doing, it's quite interesting. It's a case. You get a rare condition called an intrauterine compartment syndrome, where you get a compartment syndrome when the baby is being delivered, and this kid is from Springbuck, and he's lost the whole extensor surface of his arm, which was necrotic, debrided in Bloemfontein, and now he has healed, but his wrist is sitting at a 90-degree extension contracture. So we have to release the tendons, and we're going to do a free anterolateral thigh flap. Dr. Pienaar is going to do that, Conrad Pienaar, plastic surgeon. So it's on neurovascular bundle. So it's a proper neurovascular island free flap. So that's tomorrow. So I've got to get going. So I can thank you. Unfortunately, you guys, it's a real pity we can't chat to you. Why you aren't unmuted, I don't know. I'll take it up with Maritz. I think that's a shame. But thanks for listening. Have a lucky evening. Hey, cheers.